Hello, everyone, and welcome to today's webinar, sponsored by the Northwest ATTC, the Pacific Southwest ATTC, and the Western States node of the NIDA Clinical Trials Network. I'm Riley Vest, and I will be your host for today, and we are very excited to have Dr. Kathleen Brady from South Carolina Clinical and Translational Research Institute at the Medical University of South Carolina. A couple quick housekeeping things. First, if you have any questions for Dr. Brady during the presentation, if you could please put those in the chat and we will answer those after her presentation. You'll also be getting an email at the end of today's webinar that has a link to a survey in it, and we ask that you please take that survey as it helps us to continue to bring you the content that you're most interested in. That email will also have a link to download the slides from today and a link to the Northwest ATTC website where you'll be able to find a recording of the webinar later this week. Additionally, when you registered for today's session, you marked the type of CE or CME credits you're interested in. And for the CME credits, you'll receive an email with instructions on how to log into the Stanford CME portal, as well as some other instructions. And this slide just has some information about the CME accreditation. If you selected one of the types of CE credits, you'll receive an email shortly after the session with instructions on how to receive all of those. And all of this information is in the slides, so you won't need to write anything down at this time. And those of you who requested a certificate of attendance will receive that automatically via email in just about a week. And then finally, just a quick word about the Northwest ATTC's July webinar, which will be about incorporating Indigenous evaluation into a tribal clinical supervision learning collaborative. Meg is putting the registration link for that in the chat. So if you think that sounds interesting, please give that registration link a click. And then on to the webinar. Today's speaker, Dr. Brady, is a distinguished university professor, experienced clinical and translational researcher, and has been conducting scientific investigations and clinical work in the field of addictions and psychiatric disorders for over 40 years. Her focus is on pharmacotherapy and neurobiology of addictions, comorbid psychiatric disorders, and gender differences in addictions. She has received numerous federal research grants and has published over 400 peer-reviewed journal articles and edited or co-edited 10 books. She is the former vice president for research at the Medical University of South Carolina, and she has been a member of AAAP for over 25 years and has served as the president of the Association for Medical Education and Research in Substance Use Disorders, the American Academy of Addiction Psychiatry, and is the immediate past president of International Society of Addiction Medicine. Welcome, Dr. Brady.
Thank you. Thank you for that very lovely introduction. And thank you all for your attention today. Let me see if I can find my presentation. This is always the most anxiety-provoking part of these online presentations. Okay, great. So as you heard, I'm the PI of the Southern Consortium of the CTN. I've been in the CTN since the very beginning, and our node co-led the TMS study of in methamphetamine and cocaine dependence, which I will talk about today, but I have to admit we haven't we're in the midst still of data analysis. We haven't done our presentation for NORA yet, so I can't really talk about any of the efficacy data at this point. But so what I'm going to do is spend about half the time just reviewing neuromodulation for stimulant use disorders, which I think is a fascinating area, which shows a lot of promise, and then move on to describing our study and telling you a little bit about the results that we can release so far. I want to just thank all of my colleagues in the Southern Consortium, and also Madhukar Trivedi and the Southwestern node for their help in this study. So what is TMS, or transcranial magnetic stimulation? We're hearing more and more about it these days, but it is basically a non-invasive, I'm just going to try to move these, okay, a non-invasive form of brain stimulation which uses magnetic field changes to cause electric currents in specific brain regions through electromagnetic induction. And you can see here there's a wire coil. There is sometimes an H coil, we'll talk about that, which actually hits deeper brain areas. And the head is positioned and stimulation is delivered. That's, you can see it's non-invasive. Okay, let me see. I guess I got to use this to go forward. I want to make sure to distinguish this because there's a lot of chat around now about neuromodulation for addictive disorders. So you're probably going to hear about many other techniques, and I'm going to talk about some that I will be talking about in this presentation. But just to make sure we distinguish, repetitive transcranial magnetic stimulation is what we're talking about, can either be done to superficially, so targeting maybe the areas like the dorsolateral prefrontal cortex rather than deeper brain structures, or you can use an H coil to, if you want to target deeper brain structures. In our study, we've used this figure 8 coil. There is also transcranial direct current stimulation, which basically just involves a positive, and you can really just plug into the light socket for this, believe it or not. And then there's DBS, deep brain stimulation, a much more invasive procedure, which actually involves implanting an electrode. If you really want to make sure you're hitting deep structures, that is the way you'd want to go. So the behavior, back to TMS, the behavior and brain effects are frequency dependent. And so higher frequency, 10 to 20 hertz, actually amplifies the neural response, whereas lower frequency, 1 hertz, can lower cortical excitability and attenuate the neural response. And so as you can imagine, if you wanted to activate there are two approaches. You could either say, let's activate executive function so it can sort of take over and maybe dampen these more limbic structures that may be saying go, go, go with drug abuse. Or you could say, let's dampen the limbic arousal route by using lower stimulation. So you can say, let's juice up the executive control loop, the prefrontal cortices, for instance, with a higher stimulation, or let's tone down the limbic system with lower stimulation. And what you can see is the executive function loop, the executive control loop, the dorsolateral prefrontal cortex, medial prefrontal cortex are actually more superficial and easier to approach with the H coil. If you really wanted to hit some of the deeper structures like the nucleus accumbens, thalamus, striatum, you'd probably need to use either deep brain stimulation or the H coil. So as I just mentioned, I think the way we look at this is you're either trying to amplify the executive system, which is embodied in the prefrontal cortex, which focuses on future planning and the inhibition of impulsive decisions. Or you may want to say, let's try to tone down or decrease activation in limbic affective regions, which focus on present immediate situation and satisfying perceived basic needs. And in the case of people with substance use disorders, they view substance use, because their brain has basically been hijacked, as an immediate basic need. Just once again, you can either, TMS principle of stimulation depth is quite important really to reach these deep brain structures. You'd need something like the H coil. Reaching these higher, going about 2 centimeters in depth, you can use your figure 8 coil. How does it work? Well, TMS delivers repeated magnetic pulses to targeted brain regions at a steady frequency. It can be low frequency, as we said, around 1 hertz, which is inhibitory, or high frequency, which is excitatory. The sessions last about 20 to 40 minutes or more. They are continuous and repetitive pulses. And the purpose, it's really often used to modulate cortical excitability by either increasing or decreasing brain activity. And what are the clinical uses? TMS has been FDA cleared, not approved. It's important to understand when the FDA gives looks at devices, they actually clear them, which basically says these are safe and there's at least a signal for efficacy. It's not nearly the threshold that that a drug might require to in order to reach FDA approval. But TMS is FDA cleared for depression, major depressive episode, obsessive compulsive disorder, migraine headaches, and smoking cessation. So I want to talk a little bit about other forms of TMS, not just the repetitive TMS that we've used in the project we'll be describing, but intermittent theta burst stimulation is one you're going to be hearing a lot about as we go forward. It is a specific pattern form of TMS that mimics the natural theta brain waves. So it's around 5 hertz. So you can see it's not quite as low as a low TMS pulse, not quite as high as what we call our high pulses, but it really does mimic a natural wave rhythm in the brain. You use bursts of about 3 pulses, first 50 hertz, and then repeat at these 5 hertz intervals, which is the theta rhythm. And it's delivered in short bursts, 2 seconds on, 8 seconds off. The sessions, unlike TMS, are shorter. They're only 3 to 4 minutes per session. And it is generally excitatory, and it's generally used to enhance cortical activity, so that prefrontal cortex that we were talking about. In general, it achieves similar or better effects when compared to high frequency rTMS, and the treatment times are shorter. So it is at this point FDA cleared for depression, but really gaining popularity and being tested in other conditions like addictions because of the efficiency and the improved tolerability. And just to go through a comparison of rTMS to TBS, the theta burst, in TMS, it's continuous pulses at a fixed frequency, can be high or low for 20 to 40 minutes. In TBS, it's bursts of pulses that mimic the theta rhythm. As we said, repeating the 5 hertz at 3 to 4 minutes is the total time, mostly excitatory. So in terms of efficiency, rTMS requires longer sessions. And as you'll see in our study, we found it wasn't well tolerated, at least at the higher. We had to titrate up for some individuals because they did not tolerate the high stimulation from the very beginning. So this is shorter and time efficient, and you can see because rTMS has been around longer, it's FDA cleared for a number of indications, and TBS is only FDA cleared for depression. The other thing you're going to hear a lot about is these accelerated rTMS protocols. And this is giving multiple sessions. So when in the beginning, when we were just doing depression treatment in the early studies in tobacco, we were giving sessions once a week, and that required people would have to be in treatment for 12, 16 weeks, depending on the number of sessions that you were targeting. So someone said, why can't we deliver these more quickly and with less interval in between? Somebody's got their hand raised. Should we address that now, or go ahead if somebody's got a question now? Okay. So people started doing multiple sessions delivered in one day, actually 3 to 10 plus per day, usually spaced out by only shorter time intervals. The goal was to achieve faster symptom relief, so you might be completed in days to weeks rather than months. And it could be a particular advantage in populations where retention in treatment is an issue, and that is certainly true for substance use disorders in general, but in particular, it's true for stimulant use disorders. And so we did a modified accelerated protocol. And I'll talk about that. We certainly didn't do only one per week. People were allowed up to 5 sessions per week, but we didn't do like 3, to 10 plus in a day. And that's something I think we might want to consider in the future. You'll see retention is definitely an issue with these patients. The rationale for these accelerated protocols is that these neuroplastic changes may be enhanced or accumulated more rapidly by increasing the session frequency. What is the risk benefit? Well, there's less experience with this technique, so it does require more careful safety monitoring. And when we talk about the stimulant use disorder population, one of the issues, and our DSMB was very cautious about this, but one of the issues is if people are using stimulants, they've already got their brain, their convulsion threshold is decreased. Or if you're in withdrawal from alcohol or withdrawal from opiates, your convulsive threshold is decreased. And there is a worry that electromagnetic stimulation to a brain with a decreased convulsion threshold will induce convulsions. The fact of the matter is that is really, when you look in the literature, that there's not a lot of evidence that that happens or that these procedures are extremely risky in people with stimulant use disorders. But if people are actively using, you'll see we did urine drug screens before the sessions, and if people were actively using or reported active use, we would determine their seizure threshold before any TMS stimulation, and we adjusted the stimulation accordingly if people had used. So that is one of the things you'd have to consider carefully using an accelerated TMS protocol in these individuals. Let me just say also we had no seizures, and if you look in the literature, seizures are really very rare in this population with this treatment, but it's a concern. So one important methodologic issue is what task is the person doing before and during their transcranial magnetic stimulation? And there is some evidence, particularly from the smoking literature, the smoking is ahead of stimulant or alcohol, any of the others, is that it's helpful to show cues related to the individual substance of use before you do the stimulation, because a primed neural circuit is more plastic and more adaptive to change than an unprimed circuit. So that's one of the things we did methodologically, is that we did a brief cue exposure before each TMS session. TMS for depression was approved in 2008. So we've had, 15, 16 years of experience, but there still remain some questions. Where is the best place to stimulate in depression? It's mostly dorsolateral prefrontal cortex, but other areas have been used. Again, this whole idea of accelerated treatment, multiple treatments in one day, more rapid response. Again, brain state at the time of the procedure, refining frequencies and patterns. And then finally, probably one of the most important questions is durability and maintenance. So if TMS works in an individual, how long will it work after the last treatment? What sort of maintenance treatments should be required, and what would be the cadence of maintenance treatment in TMS? And there's been work done now. Initially, people would get multiple treatments in 1 week, come back for once a week treatment for a month, and then have once a month for a year. But all of this is still under investigation. People are sort of taking their best guess and then exploring it further. So I wanted to talk a little bit about tobacco use disorder, because that is the one substance use disorder in which we do have FDA clearance. Initially, before the pivotal study was done, there were about 24 studies, mostly positive with some mixed results and a lot of methodologic inconsistencies. Did they do the dorsolateral, prefrontal, medial? Did they try for deeper structures? And then data from well-controlled study with promising outcomes was released. And then finally the pivotal study, and I'm going to show you those results. Our site was a participant in that. But even so, the dosing, there are still dosing studies in progress when it comes to tobacco use disorder. And then also the question of combination therapy. Just because someone's taking TMS, does that mean they shouldn't be on a medication, would a medication act synergistically with the TMS? Because we do have several medications approved for the treatment of tobacco use disorder. This is the pivotal study that was used to support the FDA clearance for this. It was done by Zhang et al. It's a multi-site, double-blind, randomized trial. So in other words, a huge sham TMS, 262 subjects, 3 weeks of daily treatment, and then a 3-week follow-up. And the primary outcome was the 4-week continuous quit rate. And you can see here, this is the continuous quit rate. This is at week 6, sham active. So this is again 3 weeks after the last treatment. And this is again, week 18. So it looks like it was it was certainly a very strikingly positive effect and with some durability. So I just want to give you guys a sense of where this whole brain stimulation and addiction area is heading. And what we're looking at here is just a review. It was on 2021, only goes up to 2019. So I can tell you these graphs would still be increasing. But you can see these are the number of studies focused on TMS addiction between 2008 and 2019, you can see, or 2006 and 2019, it's a quadrupling. And then brain stimulation in general, you can see also going up dramatically. And you can see actually probably a larger increase in the brain stimulation in general studies in the last couple of years as these newer techniques have been introduced. Again, this is just to give you some idea. This is a 2024 review. This is looking at substance use in general, but you can see we've got studies of TMS, TDCS, deep brain stimulation, vagal nerve stimulation across all substances of abuse. So many studies looking at a number of different, and really it's important also to note that the target differs tremendously. Although most are focused on the dorsolateral prefrontal cortex, a few on the medial prefrontal cortex. So you can see the vast majority of studies, over half, are focused here. And that is where our study, and again, it was really based on just the wealth of literature, even though it was flawed, but that supported the DLPFC as a target. And this wealth of literature also supported, as you can imagine, if you're going to target the frontal areas of the brain, you'd want to increase their neuronal activity. So you'd want excitatory stimulation. And that's what we chose to do, is excitatory stimulation, 20 hertz, targeted on the dorsolateral prefrontal cortex. So this was a very nice review done in 2016. And you can see at this point, 2016, about 10 years ago, most of the studies are in nicotine. And in nicotine, almost all focused on this dorsolateral prefrontal cortex, a few in alcohol, second most in alcohol, and then just a mere smattering of studies in the cocaine and methamphetamine area, much smaller number. Overall, and you can see again, as I said, dorsolateral prefrontal cortex is the majority, a little of the medial prefrontal cortex. So what these studies found was across the board an acute effect on craving for drugs and alcohol, whereas very few studies investigated relapse or use. Various brain regions were stimulated. The mechanism is not well understood, but there is great potential with further investigation needed. Even though this article is almost 10 years old, I'd have to say, and you're going to see a whole lot more studies down here in this cocaine methamphetamine area, as well as a lot more in alcohol. I'd still say all of these conclusions are true. A lot of the studies are coming from China. Many of those individuals are in residential rehab at the time they do the study, so they have no access to use. And so most of those studies coming from China only look at craving. There are a few more studies, a handful that study use, but as you can imagine, that's really the gold standard. You have to look at people's use, not just whether they crave or not. I'd still say that we have studies stimulating various regions, and the mechanism is still not well understood, but really you're going to see data that shows enormous potential. So now we're going to move to a more recent meta-analysis. So this was done in 2022, and we're focused right here on methamphetamine use disorder only. What Chang and colleagues reviewed was double-blind, randomized, sham-controlled trials of TMS for, this is actually methamphetamine use disorder. There were 7 trials that met this criteria as of this review, and 462 participants. Again, all of these studies, and you can see most of them are from mainland China, evaluated craving, not use. And there is some suggestion, I'll show you the data, that this intermittent theta burst stimulation may be superior to the 10 hertz TMS, which is what we used in our study. But if we look right here, this is really the main results. If the study falls right on the 0 line, it means no effect. Sham and placebo are about the same. If it goes in this direction, what it's telling us is that there was a signal that the TMS improved the outcome. In this case, it was craving. And you can see across all of these studies, with the exception of this one, which has only a mild effect, there's an effect size that's between 1.5 and 2. So that's a pretty reasonable effect size across studies. This is just looking at the frequency. As I said, a few of these use it 1 hertz. It looks to me from here that the 1 hertz studies are the least efficacious. 10 hertz, pretty good. All of those are in the 1 to 2 effect size range. But look at intermittent TBS. Although I don't think this is overwhelmingly superior, it does really look like we've got effect sizes that are more in the 1.5 to 2 range, and probably around 1.5 on average in the using the 10 hertz. So something to keep in mind. And again, this is just brain region. You can see almost all are dorsolateral prefrontal cortex, and that looks like that is basically the best site for stimulation. Let me just, this is one example of the type of data that we're looking at, just to show you, because sometimes those other types of graphs don't really show the effect in as meaningful a way. We're looking here at the craving score. This is the control group, and this is the rTMS group, 20 treatments over 4 weeks, and they were measured at the end of 4 weeks as well as 60 days out. And again, pretty striking. This looks like it's a pretty durable effect. So there is a clear, significant decrease in craving, and it does look like it's durable. And this is another one. Again, some of these things is just so curious. It's hard to keep this all in your mind at once. Again, 50 males with methamphetamine, daily treatment for 5 days. So this is a much more increased frequency. And craving measured immediately before and 30 minutes after the treatment. What they found was you could do it to the left or the right dorsolateral prefrontal cortex, and you could use either 10 hertz or 1 hertz, which doesn't make sense really, knowing what we know about, that this 1 hertz should actually be decreasing activation of the prefrontal cortex, and this should be increasing. So curious, but interesting finding. But this is the one I find even more interesting, because I do think the craving is important. I think use is more important than craving, but also this idea, and especially in methamphetamine use disorder, where we have issues with cognitive, there is much more cognitive decline, probably related to the drug use, in individuals with methamphetamine use disorder compared to the general population, but also even compared to cocaine and other substances of abuse. It seems to be more neurotoxic. And in this study, and you think about that neurotoxicity, if you could stimulate the executive control parts of the brain and get more activation there, maybe one of the other things you could do is improve cognitive capacity and decision-making ability. And that's what we're looking at here This is something called the Iowa Gambling Task, and it basically measures impulsivity. And this is the sham group, and higher scores are better. This is our 10 hertz rTMS group. So very important, and something I think we need to keep in mind in future investigations is that measuring cognitive function and decision-making ability in these trials is probably really important as one way to look at the mechanism of TMS. So the studies we looked at up to now individually are only methamphetamine use disorder. This is an earlier review that looked at stimulant use disorder in general, but you can see all but one study is cocaine. And what you can see again, dorsolateral prefrontal cortex dominates as the site. Generally, we're looking at higher frequencies, behavior, and all of these are only looking at craving. Is there a behavioral effect? Yes, almost across the board, except this one right here. But otherwise, yes, decreased craving. So it looked like as of 2018, with about 5 to 10 studies done, that TMS could decrease craving in cocaine-dependent individuals. But I just wanted to bring up this more recent study, TMS, randomized double-blind sham controlled, and this is 80 subjects, 15 hertz, DLPFC, accelerated daily for 2 weeks, and then 12 weekly maintenance treatments, and you can see absolutely no difference. Again, only looking at craving, but no difference. So you'd have to call this mixed efficacy data. But I told you I was going to talk a little bit more about these theta burst, this intermittent theta burst protocol. Because as you saw from that methamphetamine review, it looked like there were 4 studies with intermittent theta bursts, and they looked, at least marginally, it looked like it was marginally more efficacious than TMS. And here we're looking at a study done by Colleen Hanlon and her colleagues, just recently published, 33 participants. So this is definitely a preliminary trial, 10 sessions over 3 weeks. What they did, interestingly, was measure brain reactivity to cues with fMRI before treatment and after treatment, after the 3 weeks of treatment. They also followed people after treatment to look at abstinence and drug use. They did find an increase in abstinence in the treatment group, but that actually did not reach statistical significance. But again, this is a small sample size, but yeah, you can see right here, it looks pretty good. But just at this endpoint here, it did not quite reach statistical significance, probably too small a sample size, too much variability. However, there was a significant decrease in craving before and after in the treatment group, the theta burst stimulation treatment group. And they, as I said, they measured changes in brain the brain changes that went along with this cue reactivity change over time. And this is what they found, is that, just look at the difference here between the real TMS and the sham TMS. And furthermore, what I thought was particularly interesting, they wanted to use the fMRI to actually investigate the mechanism for decreased craving. And what they found was that there's reduced activity after this intermittent theta burst in the medial prefrontal cortex, insula, and anterior cingulate cortex. And this correlated very nicely with the decrease in craving. And these are key nodes of the salience network. So in other words, if you could decrease the salience of cocaine-related cues, so that, a person in their environment could see a cocaine-related cue and actually ignore it or turn away or distract themselves with something else, that's going to improve their chances of remaining abstinent. So I like this study both because it showed positive results. It's an interesting paradigm, a little different than what we did. But I love that they used the MRI and actually that, first of all, they measured abstinence in addition to craving, and then they looked mechanistically at what might be going on in the brain. And so I thought it was a really interesting study. So with that, that's sort of my review of TMS in general. Are any questions about any of that before I go into the study itself and where we've gotten so far with analysis? I'm happy to take any if there are any. All right, let's move on. So this was a study that was led by myself and
Dr. Brady,
Yes.
I'm sorry, you just asked that question. And if you just wanted, there's just one actually that
Oh,
came,
yeah.
since we're
Okay.
just right here on this topic.
Sure.
The question is, um, I'm sorry, let me get back up here. The question is, earlier in the presentation, you mentioned that sometimes people had a hard time tolerating TMS.
Mhm.
What are the side effects, and are they so noticeable that they could compromise the blind?
Great question. Well, they do not. I don't think they compromise the blind. In fact, we always ask. We do the thing afterwards where we ask people which group they thought they were in. But we do sham TMS, which is basically all the same sensations to the scalp, but there's nothing going through it, so it's blocked from actually penetrating the skull to the brain, right? But otherwise, it's the same. It feels very much the same way to participants. So unless something's sham controlled, people would definitely. It's noisy and there's some vibration. Some people report headaches, and some people find that vibration is uncomfortable. So that's why people think these abbreviated protocols might be better, might be more tolerable. So I would say 80% of people don't complain. You anticipate, you tell them what you think this is what it may feel like, and this will get better, and it's not going to. But about 20% of people find, and particularly the higher hertz stimulation, about 20% of people might say, oh, this is uncomfortable. I can't stand 20 to 30 minutes of this. So what you could do is dial down the level of the stimulation. You could start at 5 hertz and then move up, and 5 hertz is still stimulatory, as we've seen with the theta burst. So you can start with 5 hertz and then next session move up to 10. So that is generally what we did with that 20%, 10 to 20% that found it too uncomfortable for them to really comply with the full session. We would decrease the frequency of the stimulation, and then gradually, we called it the ramping procedure, we would gradually increase it. So, and I always thought, let me just get back to this. We did some of the very early studies in cocaine dependence. I had also been working with people with depression, and I'm not sure what the difference in these there's a lot of differences in these populations. I think depressed people were just so eager and, seriously depressed, because this was treatment-resistant depression in the early days of this. And I think those people were just so slowed down, anhedonic, non-responsive, that I never remember a depressed patient complaining about the stimulation. On the other hand, cocaine stimulant users, methamphetamine users are a little more amped up, probably the frequency at which their brain is operating is different. And I found them to be more sensitive. So from the very early days when we were doing TMS with cocaine dependent patients, we had implemented some ramping procedures because they just seemed to be more sensitive than those with depression or nicotine dependence. We did that trial too. So anyway, talking about TMS for stimulant use disorder, this is the lead team, folks from our node, and Manish and others from Southwest. And we have to thank Geetha for being our NIDA person, really helped us. 4 sites, MUSC, Southwestern. We also had Colleen at Wake Forest for the first year or two, and then we had San Antonio for the first year or two. We'll talk a little bit about that. The primary aim, really, this is a small study. It was never powered for efficacy. It was a pilot study, basically. So we were looking at the feasibility of up to 30 treatment sessions. And so the outcome was the percentage of participants who obtained at least 20 sessions. And our hypothesis was that 75% of participants would receive 20 or more treatment sessions. We only used efficacy as a secondary aim because we weren't powered for that. The outcome was percent negative of the last urine drug screen per treatment week. So 7 days, that last, the 7-day period, the last urine drug screen. And our hypothesis was, of course, that the rTMS folks would have a higher percentage of negative drug screens compared to the sham group. We had some exploratory objectives. We wanted to look at the impact of rTMS on the self-report of substance use using the timeline, craving, mood and anxiety, sleep, EEG, retention and treatment, and then health, lifestyle, and functioning. And we were slated to recruit 160 patients with moderate to severe, either methamphetamine or cocaine, stratified because it is a treatment for depression, stratified for both depression and methamphetamine or cocaine. We were stimulating the dorsolateral prefrontal cortex with 20 megahertz, double blind with the use of the sham, and follow up at 4 to 8 weeks after the last TMS session. And let me just say that we started this study during COVID. So our recruitment initially was very slow for obvious reasons. It's a real hands-on protocol. A lot of protocols you could sort of move to virtual and do lots of things virtually. Not much you can do virtually when you're doing a TMS protocol. So people had to come in often. So we lost a couple of months just sort of, revising and figuring out what we were going to do to make it safe during COVID. And we ended up only recruiting, we extended our recruitment by a month or two, and we ended up recruiting 130 participants. So the first year or two were not very good because of COVID. We screened people, randomized, 30 sessions across 8 weeks, end of treatment assessment, week 12 and week 16 assessment. And just to, this was our plan. We were looking for 80 cocaine use disorder, 80 methamphetamine. So with 4 study sites, 40 participants per site. Important inclusion criteria. Obviously, they had to have the diagnosis. They had to have used it at least 10 of the last 30 days. They could not be in a treatment program, but they had to be interested in decreasing their use. And then if they were prescribed benzos or anticonvulsants, if they were on a stable dose for at least 4 weeks, they were accepted. In terms of exclusion, you can see seizures was a concern, any unprovoked seizures. If they had moderate, severe, any other substance use, they were excluded. Let me see what else. Yeah, brain lesions, that sort of thing, and any prior experience of TMS. So we gave 30 sessions over 8 weeks. The sessions were offered daily, so somebody actually could complete this protocol early in 6 weeks. We really did allow for flexible delivery, and they could have up to 2 sessions in one day. In fact, a lot of people started that way. We explored EEG as a biomarker for treatment efficacy. We did it at baseline and at week 4. And then, as we said, we used EEG coordinates to place the coil over the dorsolateral prefrontal cortex. We determined the motor threshold every 10 sessions. So that's basically looking at seizure threshold in a peripheral manifestation of brain excitability or seizure threshold. Or if a person came in with a positive UDS or they reported using, we would redetermine their motor threshold at that point. And then as I said, we did the cue reactivity session immediately before each TMS or sham session. We did use contingency management for the active treatment and follow-up visits. We had daily digital monitoring of craving, use, mood, stress, and sleep. 2 ways. We use sleep via surveys, basically the Pittsburgh Sleep Inventory, and we also monitored sleep using actigraphy. We did the EEG at baseline in week 4, and everybody was offered a cognitive behavioral therapy educational module delivery by the same platform that we were using for their daily digital monitoring. They were not required to do that to continue participating in the study. And we haven't even looked at that data yet to see who chose. Lessons learned, as I talked about the ramping procedure, some patients did not tolerate the full dose of TMS. So they would have up to 10 sessions to ramp to the full dose. If they did not reach the full dose by the end of their 10th session, they were continued in the study with their dose documented. I think everybody did end up reaching the full dose by the 10th session. And additional ramping up to the full dose was attempted every 5 sessions for participants who did not attain the full dose. But I think everybody eventually made it to the full dose. So now I'm just going to talk a little bit about the results that I can release so far. This is pre-screen, screen, and randomization. The main reason I'm showing this is something everybody already knows. Here's the total number of people we pre-screened, and all I can tell you is you need to pre-screen a lot of people to get just the few participants. As I said, we had 129 participants randomized, and it was basically about 38% of those screened. And if we just look at, this is how many were screened at each site. As I said, Wake Forest had to terminate early because Colleen left the university. But you can see we ended up with about 41% with primary cocaine use disorder and 59% with primary methamphetamine use disorder of our 129 randomized subjects. Retention and treatment. One of the things you can see here is, remember, we were targeting 75%. You could see we were targeting 100%, but you could see what we ended up with, quite a bit of site variability, 86% down to 73%, but 75%. Retention and follow-up, pretty good too, still at 75%. And you can see, again, some variability between sites. Number of TMS sessions performed, and this is sort of interesting because you can see we've gotten, and this is all reflected in that retention treatment. Some of these people just didn't, they dropped out prior to getting a lot of sessions, but we have really a nice cut point here at about 18 sessions. And as you know, 20 is the amount that's used in the treatment of depression. So we've got a fairly good cut point here to look at people that got 18 or more sessions versus 18 or less, just to see if there's, number of sessions contributes to efficacy in a way that you might, or we could do just an analysis of just these folks that got what we think is an adequate dose of therapy. So what is it that predicted retention? Right here is overall. So this is the midpoint of retention. You can see females were slightly less likely to be retained. Again, I think females were more sensitive to the actual stimulation effects. Other things that sort of stand out for some reason, Hispanic or Latinx, although this is a small number, that's negatively associated with retention. This one's very interesting. We can see our cocaine people versus our methamphetamine. We had better retention in the cocaine group. Sham and rTMS about the same, which really speaks to the adequacy of the sham control. If TMS was really more painful, you'd probably see a bigger dropout there. But we had huge site differences in retention. You could see here, Wake Forest did very well. One of our sites did not do very well. So there were big differences in retention. This was really, again, associated with some logistics at that site. So who is it that we recruited? Well, you can see primarily they were males, 74% male, 26 females. And, the vast majority were white, but a good significant, or a small, almost majority were white, significant percent of Black or African-American participants. Let's see. Polysubstance use. Remember, we excluded anybody that had severe, moderate to severe substance use of any kind. But what you can see here is, and this is of everybody that was screened, not just the ones that made it to randomization. And you can see a lot of them were using other substances, and most commonly it was alcohol. In fact, that was the most common other drug use. And what you can see is that that was also more significant in the cocaine use disorder group than in the methamphetamine use disorder group. In addition, let me just see here. If we use it, and this is polysubstance use per timeline follow back. And this other group, so you can see here a couple of significant things. As we said, alcohol more common in cocaine use disorder than meth use disorder. This is everybody that entered the study randomized. The previous slide was everybody that was screened, for which we had the data. And you can see the other significant is, do they use things other than their non-primary stimulant? You can see that's more common for the people with cocaine use disorder, and other drugs you can see more common in methamphetamine use disorder. This is sedatives, benzodiazepines, hallucinogens, inhalants. So we saw significant baseline differences basically between not only in retention, but other factors that are probably associated with retention between this cocaine use and methamphetamine use disorder group. This is just pointing out the significant areas. And this is just looking at the median days of use of other substances per timeline follow back. And you can see blue is our cocaine group, red is our methamphetamine. You can see this alcohol, marijuana, that really this cocaine use group comes in with lots of poly substance use, much more so than the methamphetamine group. So the CUD group had more moderate to severe comorbid alcohol use disorder. Even in the randomized cohort where the moderate to severe were excluded, polysubstance use was very prevalent. And so really the importance of investigating the safety of treatment interventions in polysubstance use is clear. And any of you who heard Nora speak at the CPDD meeting or other places, studying polysubstance use is definitely something that's high on the NIDA priority list. So conclusions and future directions. Neuromodulation certainly shows promise in the treatment of stimulant use disorders. There are many unanswered questions. As we know, dropout was a problem, so the accelerated treatment protocols, we really need to explore them and explore the safety of those. I also think this data, looking at theta bursts, so just a refined frequency and pattern of TMS delivery, shows promise. And then finally, looking at the durability of the effect and what maintenance protocols might be useful in exploring those. I think CTN-0108, once we finish all of our data analysis, is going to provide some very valuable information that will answer, I think, some of these questions. And as with all good research, it'll provide information that leads to more questions. So with that, I will conclude, and I am happy to take any questions. Sorry, I'm heading in the wrong direction.
Okay, you did a really great job explaining this. And so I was going through and you have answered most of the questions that we had. We only had a few. We have pull back up here. And the first question is, and you did kind of go over this, so I'm just going to ask it again. Maybe you can highlight it. Can the TMS approach be used in other disorders, e.e. narcotics and things like that?
Yeah, okay, so I'd say if we go through the substance use disorders, most evidence is in nicotine dependence, where there is FDA clearance. So that's actually second most is in the area of alcohol. And again, I'd say that data is fairly mixed. It's not really overwhelmingly positive, but there are some positive studies. Third is going to be stimulants, the literature that we just reviewed. And then after that, There are some studies in opiates. I'd say those lag behind in terms of both the number of studies and the quality of the data, but there's no reason to think that it might not be useful there, especially if what we're talking about is a basic brain mechanism that would underlie all addictions, which is basically that the nucleus accumbens and these lower limbic structures are dominating and they need more executive control. If that's, and theoretically that underlies all substance use disorders. You're basically going at a very common mechanism, so there's no reason to think it wouldn't act across substance use. In other words, be sort of a transdiagnostic treatment.
Perfect. Thank you. Okay, the next question is, have you noticed any significant differences in results with patients who have co-occurring depression and substance use? I think you hit on this a little bit, but
I did a little bit, but not, one of the things that we found, we had less depression than I would have expected, considering the fact that depression and comorbidity with substance use disorders is one of my favorite areas to study. And there's a lot of comorbid depression in stimulant use disorders. However, as you noticed at the beginning, we randomized to we stratified, so we put people with active depression across groups. And when we did a separate analysis of depression, there was no significant difference between the response of people with depression plus stimulant use versus those without depression. But the bottom line is we didn't have enough people with depression and stimulant use to really expect to see an effect. What I would say is the one area where this has been studied, so this is an area where probably the opiate literature is vast, is larger than, and the alcohol literature much larger. So there are several studies of TMS specifically in opioid use disorder and comorbid depression that look good, and alcohol use disorder with comorbid depression. So in other words, they only accepted people with both disorders. And this was before, these are earlier studies before TMS started to be more widely used in substance use disorders. So the idea was, hey, it works for depression. Why don't we take depression complicated by these other things and see if the idea was, if you're depressed and you have alcohol, does the alcohol use make it difficult for TMS to show its benefit? And that was not true. So people with alcohol plus depression or opiates plus depression their depression responds to TMS, their substance use went down. But in those studies, substance use wasn't the primary outcome.
okay. Next question is, has there been any success with engagement and or retention for people with meth use and co-occurring psychosis or paranoia?
Wow, that's a great question. I don't know that I know of any studies specific to that. The only thing I can say is that I do think the best approach for retention in stimulant use disorders, any of those with or without psychosis, is really leaning heavily on contingency management, particularly early on in the course of engagement. So basically, I think about using contingency management in that case as a way to really keep people coming back so that you can get a therapeutic dose of, whether it's TMS, whether in the case of people with psychotic disorders, whether you need, they have adequate antipsychotics on board, any of that kind of stuff. I think contingency management is very powerful in the immediate moment to keep people engaged, but we obviously can't keep up, using really powerful and frequent contingencies over the long haul. So it's not a great strategy in terms of maintaining these folks on treatment, but I think it's perfectly justified to really use the best contingencies that you can pull together in the early stages of treatment so that you can get antipsychotics on board, other adequate treatments started, so that maybe then the individuals will become easier to engage, if that makes sense.
Okay. Thank you. The next question is, would a patient with TBI and SUD be a candidate for rTMS?
That's a really good question. And I think it just depends. And that would be a patient we would have to have had scrutinized very carefully. Often TBI is accompanied by seizures or other, other signs of, signs of mood instability and other things. So I think if there was a clear, my thought is if there was clearly, certainly if the TBI was associated with seizures, you probably wouldn't want, seizures are a contraindication to TMS in general. But even if they had been associated with a lot of mood lability or impulsivity or anger episodes and stuff, as often can be a sequelae of TBI, I think I would be cautious. I don't think it's an absolute contraindication, but I think if there's some indication that they've got a brain injury that has contributed to pathology in other ways, I would be concerned that they might have some sort of an aberrant reaction to TMS. So I would probably proceed, but I think I'd proceed with a lot of caution. In other words, I wouldn't do multiple day treatments or anything like that. I'd do a treatment and monitor for a couple of days before I did a second treatment.
Okay. All right. We got a lot of questions coming in. The next one is, did the people that drop out say what was their influence for their choice to stop the treatment?
It's like most studies. I don't know if you guys have the same thing. Almost everybody that drops out is lost to follow-up when you talk about this population. I don't recall. We will at some point look over the adverse events, related to dropout. But as of this point, I would say, and we'll know, like if there are more complaints prior to dropout in people that dropped out versus those that stayed in. But as of this point, I think the majority of our people that left were lost to follow-up or left because of other, it was more like logistics around making it into treatment, job, transportation, that kind of thing. I think that's our majority.
Sure, sure. Okay, thank you. This is a bit long. I'm just going to read it though. It says, of course, thanks for the great overview. The strategy to do repeated stimulation sessions during a day or at least multiple times per week would be especially well suited to a residential addiction treatment setting with tracking post-discharge for substance use outcome tracking. Is this the next step in the research arc?
That would be certainly one very reasonable step, is to do some very intensive treatment in a short stay inpatient unit so that you could follow them afterwards for relapse. Problem with a lot of these, the studies that come from mainland China, is those people are often in that rehab facility for months and with very little follow-up afterwards. So I think you'd have to have the kind of, you wouldn't want one that was too long of a stay. You'd want to have the treatment and then really be able to look at the effects of the treatment within, weeks to a month after. But I think that's one potential way to really study these intensive multiple sessions per day type of protocols and still be aware of safety issues. But on the other hand, I do know some people, in fact, Manish Shah at UT Southwestern is using some accelerated protocols with methamphetamine use disorder right now in outpatients. I think the key there is to just really monitor for safety on a daily basis. Nobody, even if they have 3 or 4 sessions, they stay for an hour or two to make sure everything's copacetic before they leave, and they are followed basically the very next day. So I think if you choose to do some of these things that we think might be riskier, but we really don't know, on an outpatient basis, it's, you really have to follow closely.
Okay, sure. Thank you. Okay, the population you studied did include females who were using oral contraceptives, I think as you wanted to look for safety concerns. Did that affect the results in any way?
We haven't gotten that far. It's a really good question. And we took people on basically they couldn't be pregnant or they couldn't be at risk of getting pregnant. That we didn't want anybody getting pregnant during the study. So we have not really dug that far into the data, but that's something we will definitely be taking a look at. Problem is, we're going to have to look at women with and without oral contraception, and we only had 26% of our population were women. So I'm not sure we'll be adequately powered, but I'm sure we'll be looking at medication effects along with the TMS.
Okay. And then this question is, what about NFD?
What is
I,
NF?
Edwina, I'm sorry if I'm pronouncing your name incorrectly. I'm not sure what NFD is either. If you can type that in the chat and we can come back to you. Um, let's see. How does the efficacy of TMS compare to traditional behavioral therapies in the long-term management of stimulant use disorder, particularly in terms of the neurobiological changes and relapse? Great.
I don't think we really have all that data yet. The only thing I'd have to say, and this is, I don't think I'm speaking out of line at all when I say that even those people that are really expert in, so first of all, we have no medications for the treatment of stimulant use disorders, either methamphetamine or cocaine use disorders. So no comparison to make there because there's just nothing that's been proven efficacious. The things that have been shown to have some modest efficacy are behavioral treatments, contingency management, CBT, the matrix model. Even at that, I would say that these models, everybody says that these are hard to treat disorders. The treatments that we have are only modestly efficacious, and the comparison between TMS and those treatments really hasn't been made, but I think almost anybody would say that there's no reason why people couldn't get TMS plus those treatments. So there's nothing wrong. People who are being treated for depression or smoking cessation are generally receiving the standard of psychotherapeutic interventions. So we don't necessarily need to do an either or. I think a combination study might be of more interest. But right now, we don't have anything that's particularly efficacious for this group. We clearly need some improvement.
Okay. And then Edwina got back to us. It's neurofunctional disorder, i.e. those with epileptic-like disorder due to trauma.
Yeah, I think, Edwina, that it's a great question. I'm not aware of anything specific in this area, although there might be from some people in the depression, the depression folks might have explored this. In our study, and probably in most of the ones most of the studies looking at TMS and in substance use disorders, because we're talking about a non-FDA approved or cleared use, we probably would exclude somebody, even if it was a neurofunction, even if it wasn't a bona fide seizure disorder that was determined by EEG study during the episode. I think if somebody reported seizures, we would have excluded them.
Okay. And is this the same technique offered to the general public through companies like Neurogest?
Well, it's the same instrument. I think, what differs is we don't really know, from companies like Neurogest, you just don't know what kind of protocols they're following. You don't know how they're determining, so in other words, if you're trying to target the DLPFC, some studies actually even use MRI to make sure they've got the stimulator located in the right place. So I would say if I were going to someplace that was more like a commercial entity offering TMS, I would probably really want to check on the some of the details of what they were offering and what kind of protocols in terms of frequency, number, that sort of thing, just to make sure that they were aware, because it's primarily approved in depression, mostly used in that. So, and it's looking increasingly like you might not want to use the exact same protocol on depression as you do in stimulant use disorder. So I'd want to know more about what the company was actually offering. But the instrument's probably the same.
Okay, thank you. Sure. I think that is it. If you have any other questions for Dr. Brady, could you please put them in the chat now? We'll just give it one more minute or so.
I see one here about changes. I pulled the chat up, changes
Okay,
in
perfect.
connectivity that correlate with the improved outcomes. And that is definitely one of the things that we're looking at. That's why we did the EEG. MRI would have been even better, but that was just, in terms of expense and just the logistics of it, that would have been difficult to add to this study. So instead we added EEG before and at 4 weeks. And since we're really just looking at the efficacy data now, we don't know whether let me just put it this way. We definitely saw EEG changes after, and changes in which really reflect changes in neural connectivity and reflect changes in the activation of certain networks like the salience network or the limbic network, executive control. We saw changes that were the kind you might be expected to be associated with improvement after 4 weeks of the TMS. But so for instance, you'd expect more executive control, and maybe the salience network around cues would be turned down a little bit. So we're very encouraged by the EEG results. We have not done the work that it's going to take to look at the correlation between EEG changes between week 1 and week 4 and clinical outcomes like craving or substance use. But I would remind you that that article I showed, Macaulay et al. 24 to 2024, using the theta burst stimulation, was they used fMRI before and after and showed some very interesting correlations between decreased craving and changes in salience network connectivity. And I think we are hoping that we can both verify and maybe even amplify those findings through our EEG data, but we haven't done the full analysis yet. But that's a great question.
Wonderful. I don't see anything else coming through. I personally wanted to say thank you, and I hope I used to work in the prison system as a drug and alcohol counselor, and I hope this is very exciting. And I really hope that in the future this can even be used for incarcerated individuals with substance use disorder
It
because
could easily be, I mean, it's really technically and just sort of logistically, this is not hard to do. You just need to get the machine and get some people trained up. So it's, it's real. And the machines are not that expensive. It's not like an fMRI or something. So it is entirely possible that this could be used in prison systems if we find that it's efficacious. I think that would be a really good use.
that's great. Oh, let's see what a couple more. Got a couple more minutes if you want to answer these questions.
Well, yeah.
So
This is one about correlating rTMS with dementia or Alzheimer's. Oh, what a great question. And you're going to make me go back to the literature and see, because I honestly don't know, but I showed you the data looking at cognitive function before and after TMS in methamphetamine use disorder. And if you think about just increasing executive function and increasing the activation of the executive networks, you might imagine that's exactly the first thing that goes down in people with dementia. There's there's clear data that their executive function, their judgment is impaired. And I'll bet you somebody's done work on TMS and dementia, but I I don't know the facts about that. That's definitely worth doing a Google search on for sure. I think it's a great question and really a good idea. If nobody's done it, maybe you should do it because I think it's a great idea.
Absolutely. We have that one last question, and then we can close up for the day. Wrap it up.
Okay.
What about the use of rTMS for 80? I'm sorry. Does rTMS help decrease the use of medications in patients with SUD? That is a very good question.
Yeah, again, that's data we just don't have. We probably won't expect to see much of that in the meth and cocaine population because they're not on a standard medication regimen. It'd be really interesting to look at that in opiate dependent people on buprenorphine or methadone, to see if a positive response, if you took people on buprometh or methadone and tried TMS and they had a positive response, would they decrease their medication use? But we won't answer that in this study. So, but it's an interesting point. Yeah, the use of TMS and ADHD and autism because of the lack of executive function. Same idea as with dementia. And I think it's a really interesting idea, and there may be data out there, but I just don't know what it is. But I think I think again, this idea that it doesn't surprise me at all that you could improve executive function through the use of TMS. I think that makes good sense logically. So looking at TMS across disorders where executive function is impaired really makes a lot of sense, but it's just not an area I know a lot about.
Sure.
But that question brings up some questions in my mind.
Questions.
Thank you.
Thank you so much, Dr. Brady. This was an excellent presentation. Everybody's saying thank you. We hope you have a wonderful day, and we hope that you'll come back in the future and talk with us again.
All
And
right. Good to see
thank
you
you so
guys.
much.
Thanks for your attention. Bye-bye.
Bye.